I listened to some recorded interviews with Dr. Cameron as I was preparing for this talk, and there were a couple things that really stood out. He, of course, is the renowned professor, chair of surgery at Johns Hopkins, and Jedi Master of the Whipple procedure. A few things that came through that I think will stay with me. One is what a generous acknowledger of others' contributions he was, and I think Jennifer Sang is such a great example of this too, but he could hardly go a few minutes without acknowledging the contributions of others, even in interviews that were designed to highlight his own accomplishments. The second thing is I think the world would be a much better place if we all talked to each other and about each other with the same reverence and love that Dr. Cameron used to speak about the Whipple. I think we can go home and start doing that perhaps. And then the third thing is, when asked why he chose the Whipple as the procedure that he would gain mastery of, he said it's because there was so much potential for improvement. At the time that he took on Whipple as his special procedure, his beloved procedure, the mortality rate was about 25%, and he thought could only be improved. And that really connected to me because that's why I care about equity. And I'll talk about this, but the kind of inequities we have in the United States in pretty much every health outcome that matters are not subtle. I'm an ER doc. We're not subtle people. It's like, what can you see from space that needs to be addressed? And that is health equity. And that's what I'll try to convey during the talk today. This is a family history. It's my own. The box all the way to the left is my very beloved maternal grandfather, and I just wanted to acknowledge, since I had this chance, how much your skill and dedication, compassion, your commitment to the science make real differences in people's lives. But I don't think you could find a family on this planet more appreciative of the work that you do. So, what will we be talking about? Health equity in the United States. We'll talk about some mechanisms of inequity, and I will emphasize in particular inequities in the way that we develop our work and treat our workforce, just because that is what I think, have the most opportunity to have impact on. I'll link DEI efforts and health equity for the population, and then we'll end with some solutions. I will note that although there are many types of inequities, the focus is on racism and sexism just because those, from a data perspective, are the easiest to talk about, but I don't mean to exclude many other forms of equity. The data on gender does tend to be gender binary, and it's so important to acknowledge that none of us can be simply reduced to any single characteristic, and we really are, and what we experience in the world is a combination of all of our identities, but those intersectional impacts, whether we're talking about clinical outcomes or professional outcomes, are really hard to capture, so we tend to really boil things down to kind of gross differences between people. Lastly, if you want any of the references for the talk, you can use that QR code or the link at the bottom, and that should get you into a Google document with all the references plus some supplementary reading. And if you don't catch it right now, I will also have it at the end of the program as well, at the end of the lecture. So just starting with a couple of basic definitions. This is from the AMA and AAMC Guide to Language, Narrative, and Concepts. Health equity is the absence of systematic differences in health between more and less disadvantaged social groups. Makes sense? The way I think about it in my head when I walk into work is every patient who walks in the door to our facilities should feel that they were respected and cared for to the best of our ability. That should be their gut feeling as they move through our spaces. And then when we look at the data, we find that it's statistically true, their impression, in terms of patient-oriented health outcomes. We talk a lot about diversity, equity, inclusion. I add on belonging often. And I wanted to drop these definitions too. Diversity simply refers to our differences, the many identities that we carry. But valuing diversity means we recognize the differences, acknowledge them as a valued asset, and strive for diverse representation as a critical step towards health equity. Equity itself is fairness and justice. It's not the same thing as equality. It means that we identify and overcome uneven distributions of power, as well as barriers arising from bias or structural root causes. And finally, inclusion is a set of behaviors, in some what we refer to as our culture within our organizations, that encourages employees to feel valued for their unique qualities and experience a sense of belonging when they walk through our doors. So what's the state of health equity in the United States? I think I've already given you a hint that we're not doing as well as we could. This is a recent report from the Commonwealth Fund that states the United States ranks last overall in health in healthcare, despite spending far more of its gross domestic product on healthcare, the U.S. ranks last on access to care, administrative efficiency, equity, and healthcare outcomes. These cost-related access problems, things like skipping needed doctor's visits, tests, treatments, follow-ups, or prescriptions because of cost in the past year, these are all factors that mean that we pull away from like countries. We completely distinguish ourselves in terms of our inequities. So the U.S. is the country all the way to the right on this graph. So it's not even like we're close. However, I will say that if you took out that vast inequity, we would then come closer to our other peer countries. Again, this is our healthcare system performance score in terms of equity. We're not even in the pack. We pull ourselves away in terms of equity. If this were a measure of excellence, we would surely celebrate this, but this is a measure of actually our failure. Again, viewable from space kind of lack of performance kind of failures, and that means that it's all of our responsibilities. There's no equity expert who can come in and solve this for us. I know we're all kind of over talking about COVID-19, but I will say it was such an exemplar of inequity in this country, wasn't it? Mortality rates devastated our country, but when you looked both accrued and adjusted rate, were experienced so differently depending on your factors like your age, your race, and ethnicity, with some groups experiencing many, many more times of impact in terms of both morbidity and mortality. This led to largely, it was COVID's impact and many other health problems, but this has really led to a sharp drop in our life expectancy. So going from blue to green, this is each year from 2019 to 2021. At the bottom, you can see the categories: Hispanic, Asian, White, Black, American Indian, and Alaska Native populations all lost years. But again, the magnitude of the loss was extremely different based on groups, with the largest loss experienced by our Indigenous population, more than 6.6 years in life expectancy just over this period of 3 years. Some of these changes are so dramatic. This is data from California, where they looked at what happened to the gap in life expectancy between the richest and poorest percentiles. Started out wide, but has increased dramatically. Again, 11 and a half years in 2019 to 15 and a half years in 2021. These are the kind of discrepancies and kind of losses that will take generations to correct, and again, will take all of us to correct. So what are the reasons for those things? And I know, in healthcare, naturally, we focus on the things that happen within the health system or at the bedside, and we should. That's our full responsibility. But I think it's also important to really understand the whole arc of compounding disadvantage, the weight of inequity that comes with our patients when they arrive to see us. And people, have lived their entire lives with those disadvantages, and at baseline have such profound differences in social advantage based on, any of these factors, not just race, ethnicity, sex and gender, gender identity, sexual orientation, language, age, disability, relative poverty. You can go on and on and on. But they have all these baseline differences that have accumulated over time. This, again, is written up as kind of a COVID exemplar. But what we found is that, when COVID started, we had all these inequities in terms of workforce roles, the kind of benefits you got, the sick leave you had, your generational wealth and your ability to tolerate a period without work or while you were sick, your living conditions, whether you could do something like social distancing, your caregiving roles that did not allow you to distance from the ill, what was your pre-existing burden of chronic disease that made you higher risk to become gravely symptomatic, to have morbidity and mortality from COVID? What was your access to high quality health care? What were your experiences of bias and discrimination that meant that when you went there, you were likely to get high quality care and to trust that care? And then what was your inclusion in clinical trials and new knowledge base? All these things were differential based on social advantage, and I think it explained the kind of differences in mortality during COVID and in changes in life expectancy. These things translated into disparities in exposure, in this case to the virus, and susceptibility to contracting disease and disease severity, accessing timely info, care, diagnosis and treatment, and disparities in evidence base. And those things all come together, however they come together, additively, synergistically, and lead to unequal rates of illness and death. And so this, kind of expansive view on social disadvantage is what we need to bring to our studies about Health disparities. Just one example from your field. This is a National Cancer Database study. The inclusion criteria is patients who were diagnosed with a malignant neoplasm of the gastrointestinal tract from January 1st, 2014 to December 31st, 2017. Kind of a remarkable study just by sheer numbers, over 500,000 patients. They adjusted for different things across 3 model types, for sex, age group, race, and organ site, primary payer, facility type, and Charleston comorbidity index score, and then finally for clinical TNM stage group and grade. And what they found were a host of concerning disparities. These are just a few highlights. In terms of clean margins, a 4% disparity in negative resection margin for Black patients relative to white patients. Black patients were 11 to 14% less likely to have adequate lymphadenectomy. Black patients were 8% less likely to receive chemotherapy and 35% less likely to receive radiotherapy. These are recommended therapies. And then they found that it wasn't just the surgical outcomes. Even with the negative margins and adequate lymphadenectomy, Black patients had a higher risk of death. And so I think, once again, a lot of questions about why an individual patient might go through the system, not receive the same care as a like patient of a different race. But I think our job is to understand, to see the full arc of the compounding disadvantages that may have affected a patient who comes into us based on their identities, and then also to really hone in on what are the things immediately within our power to change or to start asking key questions about. So let's talk a little bit about mechanisms of health inequity. And again, I'll focus within our institutions, although I think we do, in this day and age, need to have a broader view. This is, again, from the same Guide to Language, Narrative, and Concepts, and again, using racism as an exemplar. We are all over the map when we talk about things like racism and sexism. I think we talk about big structural forces, as I just did, and then we tend to talk about interpersonal racism and how hurtful that is. In this section, I'll really focus on institutional racism, because I think there's kind of a big bang for our buck if we think about what are the institutional, structural reasons within our institutions that lead to disparate outcomes that can actually be altered, that are actionable, so that we can try to minimize the harms that we do in terms of health equity. So, and I want to emphasize, many of these things are baked in, so it's not like we walk through the day and we're like, I think I will execute some inequity over here. I think we all come in hoping to do the best that we can for all our patients, but what happens if you work in a system in which inequity is baked in, and just by following the rules, using the EHR, using the equipment around us, what if those things set us up for inequitable outcomes? And that is actually the situation that we have. So numerous clinical decision scores incorporate race in unjustified ways in order to disadvantage patients. So the AHA heart failure risk score systematically regards Black patients at lower risk, and so kind of raise the threshold for using clinical resources for Black patients. The estimated GFR, this may have come across your radar, it adjusts the GFR if a patient is identified as Black, and that higher eGFR value may delay referral to specialist care and can delay being on a list for kidney transplantation. It's highlighted because we'll come back to that one. The UTI calculator may assign a lower risk of UTI if a patient is Black. Same thing across pulmonary function tests, VBAC scores, fracture risk assessment tools. Really, any field that you're in, you can find a systematic way in which we disadvantage patients based on race, ethnicity, and other factors to receiving high-quality care. Very addressable. I think sometimes there are things that are systematically incorporated into the way that we practice and allocate resources that are almost invisible if you're just kind of a clinician working the system. This is a study out of from a bunch of researchers in Berkeley that looked at an algorithm that was used to manage the health of the population across an academic health system. This health system used a risk score to identify patients who had complex high health needs that required care management resources. So, the high utilizers in our system, and they would assign expensive and intensive care management resources to those patients. Things like a coordinated care team, dedicated nurses, extra primary care appointment slots, other things that were generally hard to come by because these were high needs patients. But here's the problem. At any given calculated risk score, The yellow line is white patients in this program, and the purple line is Black patients. At any given risk score, the Black patients were considerably sicker than the white patients by the time they got flagged for referral to this program. Why? It's because the algorithm was based on the healthcare costs rather than the illness. And so what this meant was that unequal access to care meant that they spent less money caring for the Black patients to begin with than they did for the white patients. So the disparity in access wound up compounding the inequity by race. They calculated that remedying this disparity would increase the percentage of Black patients receiving additional help from 18 to 47%. These things are addressable. Here's another one, and this is one that's kind of fun to think about as you just walk into your clinical environment the next time. Our physical environment is sometimes stacked against patients in ways that exacerbate inequity, and I think the most stunning example of this has been what we found out about pulse oximeters, just put on our fingers. There have been a number of studies now that do this, that obtain paired arterial oxygen saturation at the same time that you have a measurement from pulse oximetry. And what they found is that many of these pulse oximeters differ based on how dark your skin is. They weren't calibrated and designed to perform well across the wide variety of skin tones out there. And so in this study from the University of Michigan, they found that among those patients who had an O2 sat of 92 to 96 on pulse oximetry, an arterial oxygen saturation that was contemporary of less than 88%, this is what they defined as occult hypoxemia, was found in 11.7% of Black patients and in 3.6% of white patients. In a multi-center cohort they studied at the same time, occult hypoxemia was found in 17% of measurements in Black patients and 6% of measurements in white patients. And this was so painful to see how this played out very directly in the COVID pandemic because it's pretty clear from subsequent studies that occult hypoxemia likely led to underestimation of disease risk, underestimation and differential choices about admission, therapy with oxygen, and escalating other types of COVID therapies. And I think that's probably some chunk of the explanation for the big differences in mortality that I showed you at the outset of this lecture. And then finally, I'll end with our workforce inequities as a driver for healthcare inequities, because I think those two are so linked. There's so many inequities I can talk about. We have inequities in representation. We have specialty sorting or segregation. There's differences in compensation. Very obvious, again, from space, easy to see differences in leadership and promotion, differences in opportunity, in awards, in recognition, and also in day-to-day treatment. I'm not going to cover everything, but I'll touch on it, just a few highlights. One thing is, contrary to popular belief, we aren't making a lot of gains in terms of increasing diversity. And I know we hear about it all the time. There's lots of resources. There's always an office of this and a position of that. And I will just say, this is just one shot from a AAMC faculty roster report, but and it's only U.S. Medical School female faculty over time. But the bottom colored lines are the percentage of faculty who are underrepresented minorities, and you can see, without giving you any numbers, that those are pretty much flat lines. So I think we sometimes have this feeling that these things will organically improve, but they are not. We're seeing the same thing across surgical subspecialties. This is a study about resident diversity across surgical subspecialties, and they basically found from in 6 surgical subspecialties between 2001 to 2017, the proportion of residents from racial and ethnic minority groups remained unchanged. And again, graphically, you can see that is consistent. So I think without big, meaningful initiatives on multiple levels, we're unlikely to organically get improvements in this, which is why Jennifer's opening address was very moving and likely to be meaningful to your field. I will say segregation by specialty also tends to happen based on sex and gender. This is another study that showed that the female share in specialties tends to increase the less one is paid in that specialty. I'll just let that one sit with you. This is from the Doximetry report of 2023. They've been doing a physician salary report for 6 years running now, and they always break down physician compensation by gender. And I will say, this is so this year was 31,000 physicians. It's always in that range. They only look at full-time people working over 40 hours. I realize talking to surgeons that doesn't sound like full-time, but they do try to even the playing field in terms of requiring just looking at people who are technically defined as full-time for regular people. They adjust for specialty, for geographic location, and for years in practice. And what they found was in 2022, very similar to other years, there's a 28% difference in physician compensation. And if you estimate how that would compound over the course of a career, it would be about a $2 million difference by the time that you retired. There is no single specialty in which women on average earn the same or more than men, not one. So the idea that if we get enough women, all these equity problems will be fixed is not borne out by the literature. There is just the scale of the difference. And if you look at nursing, which historically has been largely women, that is also true, although nursing continues to be about 80% women. Men in the specialty still, in the role, still make more than women do. So it's not a numbers issue, it is an issue of how we value people. Again, I just want to nod to intersectional effects because gender is a simplification, and when you fold in race and other factors, there's a fuller story about who we value. This is older data, I think, from 2013, but just shows that if you break down by more than gender, you can see how that plays out in both race and gender, likely play a huge role in compensation. And also, all these gaps are not really improving dramatically. I think you all know, this is not specific to medicine, but I think you all know about equal pay day. Equal pay day is like how far into the year women need to work to finally earn what men earned the year before. So like, yay, we celebrate because we finally caught up. But what I didn't know until recently was that there's many equal pay days. There's equal pay day for women overall. Last year was March 15th. And then if you just take mothers, it takes until June 4th for mothers to make what men made the year before. Black women celebrate their day August 3rd. Native American women September 8th. Latina women practically have to work a full other year. So again, it's not as simple as gender and race and ethnicity are folded in there too, as well as many other social factors. Day-to-day experiences I just wanted to emphasize because it has such an impact on how you see yourself, your confidence, your ability to go through your day as a resident. This is a study that came out in 2020 that was a national evaluation of U.S. surgical residency programs. And they found that female residents were 1.5 times more likely to experience discriminatory experiences compared to men during their surgical residencies. Hispanic residents, 2.6 times more likely. Asian residents, 6 times more likely. And Black residents, more than 20 times more likely than a white resident. Again, intersectional effects, if you stratify by sex, across all racial and ethnic categories, women were more likely to have experienced discrimination. And this is important because residents who do have discriminatory experiences also report higher rates of burnouts, thoughts of attrition, and suicidal thoughts. So, diversity is when we bring people into the room. I think we then have to really think about culture, belonging, mitigating or preventing experiences of discrimination so we can keep people and they can thrive and they can contribute and they can rise throughout their careers. I could go on and talk about, representation and leadership and at the NIH and grant funding, and there's so many things to talk about that really have pretty sharp workforce inequities. But I'll just stop with this one because we're at a meeting and there's a poster session, and I love to give people things to think about while they're walking through poster sessions that are a little bit meta. So this is a study out of Brazil that I won't go into the details, but I'll just say what they found is so interesting to me and actually made me look at authorship lists so differently. They found that when women are the lead in a study, they tend to include other women on their teams, in their published papers, in the same proportion as women are available in the specialty, whereas men tend to publish with a bunch of other men. And I think that is probably true across characteristics. And I spent some time with your poster sessions, and I would just ask you as an exercise, maybe when you're bored, just as you walk through the poster sessions, consider this data and consider the inclusivity of your own teams and whether that might be something that you could change over time or even starting today. So what are the root causes of this? And this itself is it's a whole lecture, but I just want to plant a seed about how we value people differently. And there have been a couple seminal studies about that. This is one called What Happens Before. And they wanted to see from the outset, from the minute that you enter a field, what might happen in terms of bias and discrimination and opportunity. And what they did is they sent a whole bunch of professors, I think 6,500, more than 6,500 professors. They sent them this email. It said, "Dear Professor so-and-so, I'm writing to you because I'm a prospective doctoral student with considerable interest in your research. I was wondering if you might have 10 minutes when you would be willing to meet with me briefly to talk about your work and any possible opportunities for me to get involved in your research." We've all written these letters or emails, right, as we begin our path. And so the letters were all the same, but the signed names differed. And these were the signed names. And as you can see, these names were chosen because they very much convey a sense of both gender and race or ethnicity. Is that fair to say? They field tested this before they deployed it in the actual study, and with almost 100% consistency, people could name the gender and the race or ethnicity that they intended. So these were coded to signify gender and race and ethnicity, and I thought they did a pretty good job of that. And what they found was the likelihood of receiving an email response, just that simple thing, takes almost no time, but signifies interest, potential investment in this person, and opens the door for opportunity, was very different depending on if you were male, female, and what race and ethnicity you were. And so, and these are all comparisons against the white male applicants. So Caucasian female on the left, then Black female versus male, Hispanic female versus male, Chinese female versus male, and Indian female versus male. Here's another seminal study. This was a nationwide sample of biology, chemistry, and physics professors. They were asked to rate an applicant for laboratory manager. The CVs the professors were randomized to one of two candidates whose CVs were identical in every single way except for gender that was signaled by their name. And they were asked, the professors, then to rate this applicant on competence, hireability, mentoring, and to give them an estimated starting salary. The dark bars are the male student, the light bars are the female students. These are identical applicants. And this is what happened to this salary estimate. And that's where the compensation differences come from, I think, at least in part. And to be clear, it wasn't the male professors that did this to the female students. It was male and female professors that both did this in terms of ratings and estimated salary. So just to stop with a little exercise. So here's an example career scenario, and it's a very common one, I think. So this is a 41-year-old physician, about 10 years out from residency. Initial 2 years out of residency was full-time, very academically productive, high-quality work, won a teaching award, and then, as happens, had in quick succession several young children, and went part-time for about 6 years, so could really focus on childcare. And now is exploring a semi-academic job, open to leadership roles, but basically wants to come back in as a full-time physician. So what would you do with this person? And I know you think that I expect a certain answer, and I do not. Really just answer this honestly, because I was surprised. I had an impression. Anyway, so here are the available positions. So you can hire this person for part-time work with the option to transition full-time at a later date when you see that they've kind of come back to full-time and can perform. You can just put them right into a full-time clinical role. They were a promising clinician before. There's no reason that would have changed. There actually is a section chief position available that you don't have a candidate for yet. Or you can do none of the above and you can pass on this candidate. Your desk is, full of new residency grads who are looking for a job and they are really motivated, and you know that you can count on them. Who would do A? Who would do B? B is what I thought should happen, honestly, and would happen. Who would do C? Who would think this is someone who can jump right in and make a great leader? And who would actually pass on this candidate? Okay, so this person is my husband. He actually was the one who volunteered to go part-time and per diem for 6 years while we raised our first child and twins. And this is what happened. And he is a really nice guy. He's a white guy. He went to Harvard. I'm super proud of him. His CV is like a 20th of mine. But the reason I bring this up is that when I tell female physicians, and particularly female physicians of color, this story, their jaws drop to the ground because they have never, ever heard of something like this happening. This would never happen to a female physician who took time out to spend time with her family and then wanted to reintegrate. Do you agree with this? You do a lot of hiring, Dr. Sang. Does that sound? I mean, it's unheard of. It surprised me. And I just want to say why. Why is that such an impossible thing to believe? And I'll say, it was satisfying. We actually discovered this literature after this happened to us as a couple. There's something called the Motherhood penalty. And again, another seminal study from 2007. This participants examined an application. These are people who were employers in the field, and they examined application materials for 2 hypothetical applicants for a mid-level marketing position, similar in all aspects except for parental status. And in this study, they compared mothers versus women who were not mothers, and then fathers versus men who were not fathers. And what they found was that mothers were rated lower on competence and commitment, given a higher test score threshold that they would need to pass in order to get hired. They were given suggested lower starting salaries. Fewer of them were recommended for management and for hire. And the proportion recommended for hire was very low among mothers. Fathers, compared to non-fathers, they were rated higher on commitment, had a higher recommended salary, they have to take care of their family, and a higher proportion, 94 versus 85%, were recommended for management and for hire, 73% versus 62%. All these CVs were the same, except for a little flag, you were serving on a parent and teacher committee. And those were the differences. And so I think, again, it's more complicated than just gender. There are all these other factors that play in and sometimes compound the biases that we have. But we have, I think it's fair to say, valuation issues when it comes to people and our feeling about their competence, their ability to contribute into our organizations in productive ways. And I think those valuation issues translate into some of the inequitable problems that we have. So let's directly link some of those DEI to equity, to actually specific health equity gains. So this is a large study published in JAMA Internal Medicine, probably the most read and controversial study they have ever published, but it was a big national database of Medicare patients who were admitted to the hospital and kind of randomized, quasi-randomized, either male or female hospitalists. You don't go in the hospital and say, I would like the male physician who is on today, you just get randomized. And what they found was that patients treated by female physicians, hospitalists, had lower odds of death and readmission compared with patients cared for by male physicians. Strange. And then a similar study among a surgical population, after accounting for patient, surgeon, and hospital characteristics, patients treated by female surgeons had a small but statistically significant decrease in 30-day mortality, and similar surgical outcomes compared with those treated by male surgeons. Another study that looks at kind of who the physicians are make a difference. This is a study where they recruited black subjects from a barbershop in Oakland, brought them to a clinic, and then randomized them. These were all black subjects, and randomized to either a black or a non-black physician. So this actually wasn't about preference. You just got randomized to one of these physicians. And this, the subjects who were randomized to a black doctor, to a race-concordant doctor, were more likely to receive blood pressure and BMI measurement, agree to diabetes and cholesterol screening, and accept the flu shot. These are just core, important preventive health services. But because of that difference, these economists estimated there could be a reduction in cardiovascular mortality by 16 deaths per 100,000 per year, which would lead to a 19% reduction in the black-white male gap in cardiovascular mortality, which has been a very tenacious gap that we have failed to make progress on for many decades. So now we're actually starting to reduce mortality. All these studies, by the way, are so remarkable because our diversity studies of the physician workforce used to be like, do you like your physician? Do you feel listened to? Are they empathetic? And now we're just like, did you die? If there's physician concordance. We just went straight to these hard outcomes. This is one of my favorite studies. It's in my field. It's a Florida Medicare database of patients who came in and were treated for myocardial infarction. And what they found was that female patients, again, another quasi-randomized study, right? You come in and you can't choose the gender of the physician who takes care of you. They found female patients treated by male physicians were the least likely to survive an episode of care. Patients treated by female physicians were more likely to survive regardless of patient gender. And then they did something that really changed my thinking about this topic, and it's such an important step, because I do not think, despite this whole presentation, I do not think that female physicians are better, or that physicians of any race or ethnicity are better. That is not the explanation for these findings. This study examines survival in emergency departments based on the overall proportion of female physicians in each department. So regardless of who the treating physician was, what if your department just had this more diverse makeup? What happened? And they found that female patients had better outcomes from their MIs in EDs that have a higher percentage of female physicians overall. And actually the improvement in the survival of female physicians, the change in performance was particularly high for patients who were treated by male physicians. So male physicians perform better in environments where there was more gender diversity. And that speaks to Dr. Sang's point about who does diversity benefit? It benefits everybody. It benefits for people who don't even think they're the target of diversity initiatives, because it makes our entire workplace stronger. One last one. This is recent study, workforce data from the AMA master file combined with county-level population data from the American Community Survey and the National Center for Health Statistics. They looked at the association of the Black primary care provider workforce representation with survival outcomes across these counties at 3 time points. The first depressing finding was that more than half of all our census-defined U.S. county had actually not a single Black primary care physician. But they found that when they did, just increasing that workforce representation a little bit by 10% could increase life expectancy for the Black population by 30 days. And the numbers were so small, there's no way it's bringing in a Black physician and matching them to all the Black people. It again was just a marker of a community that was supportive of greater diversity. We saw mortality rates go down. Life expectancy rates go up. And the authors wrote, race is a social construct that serves as a proxy measure for the structural inequities inherent in our society, and specifically in the healthcare system. And importantly said, these are fixable health system factors, such as differences in availability and quality of care. And I want to say, no matter what we're talking about in terms of the safety and quality of care, everything gets better with more diversity. And this is true in healthcare fields, and it's true actually across industries. This is data from McKinsey Research, from Catalyst Research, and from Talent Lift, I think. And we found that gender diversity in your workforce and in leadership, and racial and ethnic diversity in your workforce and leadership leads to better patient outcomes, improved workforce engagement, productivity, greater innovation, enhanced organization performance, reduced employee turnover, and the benefit of a wide variety of perspectives. And I think these are things that no-brainer we all want in our workplaces. Diversity pays off financially. So again, data from McKinsey, companies with diverse leadership teams attain 73% more in revenue from innovations than less diverse companies. And companies with diverse boards and leadership are 33% more likely to perform above the median on profitability in terms of less diverse companies. And I think there's a vast literature supporting that the mechanisms of equitable environments include that you have improvements in personal productivity, team communication, employee engagement, creativity, innovation. And as we've seen from recent financial failures, diversity allows more precise and balanced risk assessment and tends to create a more stable organization over time. And as we've said, equitable environments create improvements for everybody. So in summary, better health outcomes entail grappling with inequities. The sources are structural, institutional, and individual. Equity leads to gains in everything we care about in our health system, and we all have a role to play. I think every single person has the ability to actually improve health equity. I'm going to end with just a couple of positive stories because we talked so much about the failures in terms of health equity. Just one that was written up in the New England Journal a couple of years ago that stayed with me. In Chicago, Black women were noted to be almost 40% less likely than white women to receive breast care at a breast imaging center of excellence, and in 2005 had 118% higher cancer mortality rate. The city mobilized around this. The Metropolitan Chicago Breast Cancer Task Force was established in 2008. There were many resources allocated to this, including quality improvement efforts, standardized follow-up, and health navigators that did individual outreach to Black women. In the 10 years after this program was established, racial disparity in breast cancer mortality in Chicago decreased by 20%, and this was not emulated in other similar studies around the country. It's also been a really remarkable story around the use of use of race in estimated GFR calculators. I don't know if you followed this at all, but it's kind of this explosion in the medical literature of faculty and scientists writing about how race was used to calculate GFR and how it doesn't make any sense. It doesn't make sense scientifically, and it clearly led to differences in resource allocation and outcomes. And what followed was really medical students around the country led efforts to have their schools and their institutions remove race from kidney function estimates. And they did. I mean, there were announcements everywhere. This one is off the page of Mount Sinai, where they decided to go ahead and remove the racial coefficient. They could not justify it to their own students. There was also a lot of literature that came out looking at the outcome differences. If you use this race-specific estimates, found there was no rationale and no benefit for doing so. The National Kidney Foundation and the American Society of Nephrologists convened a task force that reported out in 2021 and made recommendations to exclude race in kidney disease. What followed then was that based on those recommendations, the Organ Procurement and Transplantation Network, I believe, OPTN, made a policy change last year that said that transplant programs need to review those for whom an eGFR race calculator may have been used to determine their place on a waiting list for a kidney transplant. And this year, in 2023, was when the clock begins, and programs have a year to do this to inform patients and to potentially change their place on a list. So that's a wild ride over just a handful of years, and it would not happen without medical students. So just a humbling reminder that wherever we are, whoever we are, we can make meaningful differences in a pretty short amount of time. Changing equity doesn't have to be something for tomorrow or 10 years from now or 20 years from now. Yes, the big structural things may have a long tail, and there are many, many stakeholders to put in place, but there are also moments where we can make huge differences in real lives and real endpoints over a short period of time by simply caring, asking questions, and then following those questions to their natural conclusion. And that's why I want to leave you with actually 3 kind of categories of questions, because we should leave a talk like this with something to do. So at a very high level, I gave you 2 examples of how we might improve things that were broken and not right for many, many years. I think the higher level, better question is, how do we get it right to begin with? Foundationally, how do we create programs, equipment, calculators, practices that are equitable from their outset so that we don't have to wait 20, 30, 40 years and then try to fix it by 20%. That would obviously be a better approach. So you are all innovators. You are starting new programs, new clinical pathways, new equipment. How do we get that piece right to begin with? And how does your health center contribute structurally to the health of the community? Are there ways where we can really impact people much further upstream before they come to us with all of the social disadvantage already baked into their lives and their health? On an institutional level, when we walk through, look at your walls, your equipment, your algorithms with a new eye, wondering what inequities might be baked in. After the pulse oximeter thing, nothing looked the same to me again, and I hope that is the same for you. I think we can constantly question how our recruitment and selection processes for trainees, for faculty, for leadership, for awards, how do those things occur? If we don't know, could there be inequities that have snuck in? I think that is almost certainly true. And again, Dr. Seng's call for a more transparent and understood process for how things are allocated, I think makes a lot of sense and is something that we should be doing. And then, are there measurable improvements in equity over time? And if you don't know what they are, or nothing is measured, probably not. Like with resident diversity and faculty diversity, it's unlikely to happen alone without accountability and specific metrics. And then finally, on an individual level, what inequities do you see in your day-to-day interactions, experiences with your own faculty and mentees that might be solvable? How inclusive are your own teams? Just pull up your last 5 papers and ask questions about them, and then think about what you want your next team to look like. I think that could have such a meaningful difference. Or look as you walk through the poster hallways and, think about that. Does any of your scholarship address health inequities? If you have a database sitting there and you haven't asked questions about it, about health inequities, could you? That sounds like another paper to me, and a good one for a fellow or other mentee. And then finally, I think we need to stop admiring the problem and really lifting up potential solutions. So I'd say if you do already look at health inequities, is there within your literature potential solutions, or are they only observations? Because we have so very much work to do that we have to stop admiring it and really start fixing it. I really thank you for your attention. And am happy afterwards to answer any questions. My contact information is there, and once again, the link to the studies that I cited in this talk are the QR code and the link. Appreciate it.